Before starting the topic of discussion of today, I want to clarify you one thing first of all. So let me ask you whether 2:1 AB block is better or 4:3 AB block is better. So 2:1 versus 4:3. So which AB block is better in terms of cardiac output? So how do you assess that? How will you assess it? How do you calculate it? So 2:1 means about 50% of the P wave is conducted to the ventricles, right? So every alternate beat is missing QRS, right? Or you can say every alternate beat is being conducted to the ventricles, like 50% of the impulse is reaching to the ventricles and 50% of the impulse is not reaching to the ventricles. And what do you mean by 4:3 AB block? So 4:3 means 3 out of 4 atrial impulses are reaching to the ventricle, like 75% of the impulse is reaching to the ventricle. So definitely 4:3 AB block is better than 2:1 AB block, right? Because here 75% of the impulse is reaching or traveling to the ventricles. And what do you think about 5:4 block? So 5:4 means 4 out of 5 impulse is reaching to the ventricle. So 4 out of 5 means like 80%. So definitely 5:4 block is better than 4:3 AB block, right? Because in 4:3 AB block only 75% of the impulse is reaching to the ventricle, but in 5:4 block 80% of the atrial impulse is reaching to the ventricle, right? So when you think like whether 2:1 is better or 5:4 is block is better, then you can use this concept to assess it, right? Now let's go to our topic of discussion of today. So let's say you ordered basic investigation in a patient who came for pre-employment checkup, and in his ECG you saw 2:1 AB block. He does not have any cardiac symptom. He just came to your OPD for pre-employment checkup, and you saw 2:1 AB block. He does not have any family history of channelopathy, arrhythmia, any cardiac disease, any conduction problem or structural problems of the heart. But you are now seeing 2:1 AB block. He does not have symptoms. So what to do now? Since he does not have symptoms, can you ignore it? Definitely you have to rule out reversible causes of AB block, like potassium abnormality, magnesium abnormality, calcium abnormalities, hypoxia, like those things that alter the conduction system of the heart. But he have all basic investigation normal, and he does not have any family history of conduction disease or structural heart disease. So in this case, what should we do now? Should we refer to cardiologist for electrophysiological study? So since this is 2:1 AB block, you cannot assess whether this is type 1 mobitz or type 2 mobitz, because you know in type 1 mobitz there is progressive PR prolongation and there is dropping of the beat. But in type 2 mobitz there is constant PR interval. There might be prolonged PR or might be normal PR interval, but there is a drop of the QRS complex. That is type 2 mobitz. So in this case, Is there need to differentiate whether this is type 1 mobitz or type 2 mobitz? What do you understand by type 1 mobitz and type 2 mobitz? Type 1 mobitz means the problem is at the AV node. Type 2 mobitz means the problem is in the bundle branches, fascicles, right? So lower down the AV node there is problem. So we have to identify where is the problem. Since this is 2:1 AV block, we cannot locate the site of lesion. And why do you need to assess the site of lesion? Because if it is lower down the tract, patient might require permanent pacemaker. Because if you see the guideline, they say that even if patient does not have symptoms, you have to refer for permanent pacemaker implantation, because this type 2 mobitz can alternate with complete heart block, because this is high degree AV block, one of the high degree AV block. So we have to differentiate whether this is type 1 or type 2 mobitz block to find out the site of problem, site of the degeneration, site of the infarct or whatever may be. So how do you differentiate whether this is type 1 mobitz or type 2 mobitz? Can you think of any way? If you don't know the answer, I can give you one clue. You know, AV node is supplied by parasympathetic fibers, but bundle branches and fascicles, those are not supplied by parasympathetic fibers. So if you can modulate the parasympathetic tone, like if you inhibit it or if you exaggerate it, if you overexcite the parasympathetic tone with vagal maneuvers, or if you inhibit the parasympathetic tone with atropine, can you find out whether the lesion is in the AV node or bundle branches? Definitely yes, I have already told you answer. Because AV node is supplied by parasympathetic tone, but bundle branches, fascicles are not supplied by parasympathetic tone. So if you do certain vagal maneuvers and you increase the parasympathetic tone of AV node, mobitz type 1 block will worsen. Because mobitz type 1 means the problem is in the AV node and you again exaggerated the vagal tone, you exaggerated the parasympathetic tone. So mobitz type 1 block will worsen. Like initially it was 2:1 AV block, right? So it worsens. So what will be what changes you can see in the new ECG after vagal maneuvers? Like only initially there was 50% of the impulse has been conducted, but now it becomes like 25% of the impulse is conducted or 30% of the impulse is conducted. So you can assess with that earlier formula that I discussed before starting our proper discussion. So mobitz type 1 block will worsen with vagal maneuvers, but mobitz type 1 block, type 2 block does not change. It can remain same 2:1, or it can even improve. It can even improve. But don't focus on improvement. Just remember, this does not improve with vagal maneuver, mobitz type 2, because mobitz type 2 means the problem is in lower down the bundle branches, but there is no parasympathetic supply, so there will be no alteration. Now let's talk what will be the effect of atropine. So I told you with vagal maneuvers, mobitz type 1 block worsens because you increase the parasympathetic tone. But if you give atropine, atropine means you cancelled out the parasympathetic tone to the AV node. So if it is mobitz type 1 block, it will improve. It will improve with atropine. But if it is mobitz type 2 block, it will remain same or worsen. So improve with atropine, it improves means from 2:1 AV block it can change into 4:3 AV block, or it can change into 5:4 AV block. So you gave 1 ampoule atropine to patient and you then repeat ECG. You can connect to the telemetry and you can see the effect of atropine, whether this block is improving or worsening. So if it is worsened, it means it is mobitz type 2 block. If it is improved, it means it is mobitz type 1 block. So this is the way we can differentiate. And another way is you can ask patient to exercise. If patient exercises, it stimulates the sympathetic tone, and stimulating sympathetic tone means inhibiting parasympathetic tone. So the effect will be similar like giving atropine.